I'm Herbert Spiegel. I was born in a suburb of Pittsburgh called McKeesport, Pennsylvania. And I've graduated medical school in '39 and did my residency in psychiatry at St. Elizabeth's Hospital in Washington, D.C. Just as my residency was finished, the Army got involved in World War II. And next thing I knew, I was on a ship going overseas, and I was a battalion surgeon with the 3rd Battalion of the 1st Infantry Division. And I lived with 1,000 men in combat for about 6 months during the battle in Tunisia. During that time, I had occasion to work with hundreds of wounded men in various conditions and learned how to use hypnosis to enable them to endure the anxiety and the pain while I was caring for them. Impressed with that, I was even more impressed with the fact that a few days before the campaign was over in North Africa, I was hit by a shell fragment that broke my right ankle. And I remember I felt pain, and I didn't know where it was coming from at first. And when I saw a shell fragment stuck in my right ankle, I quickly pulled it out. And then my first thought was, well, if I'm hit there, where else would I hit? So an aide man come over to me, and I remember I couldn't see anything in front. I rolled over on my belly and said, where else am I hit? And when he couldn't find any place else, and I realized I was hit only in my right ankle, I felt wonderful. And then they wanted to give me some morphine. And then I felt so good about it, I was able to hypnotize myself and ignore the pain and feel a tingling numbness in the area, so I was able to refuse the morphine. And I was so impressed with the fact that even I could use self-hypnosis to ignore the pain.
Dr. Spiegel, I know this is a difficult question, even for someone like you who's been in the field for so many years, but what is hypnosis? I mean, what is your theoretical framework when you approach that question?
Well, you can't define hypnosis today unless you make one major disclaimer, what it is not. It is not sleep. Whatever sleep is, hypnosis is just the opposite. Hypnosis is an alerting operation, and today the best definition I can think of is that it is an attentive, receptive state of concentration. It involves focal attention in a receptive stance with an ability to concentrate with a continuous ribbon of picking up cues from the other person or from one's inner thoughts.
So you're saying it's a state in which you are more awake?
If anything, we are more alert and more awake in the trance state than we are in our ordinary state of awareness. There is this balance between peripheral and focal attention. And the reason we got into this nonsense about it being sleep is that there is an illusory similarity in this sense. In both sleep and hypnosis, there is a contraction of peripheral awareness, but for different reasons. In sleep, there is a general withdrawal to enable also a diffusion of focal attention to go to sleep. But in hypnosis, in order to facilitate focal attention, we have to, at the same time, contract peripheral awareness. In other words, in order to see something, we have to forget things. In order to focus on this, we have to, by design, cut out peripheral awareness. That's what hypnosis is.
Can we look at hypnosis as an altered state of consciousness? Or
Yes, in a sense, it's an altered state of consciousness, because that's a general term that means so many things that it means almost nothing. It's like
what I'm talking about is that another part of our consciousness that we have not tapped into, that we can tap into. It's an ability, a gift that we might have.
That's right. But see, our consciousness is like a kaleidoscopic. There's so many different facets to our levels of consciousness. But what we're doing is taking one segment of it and applying a puzzle form to that one segment and using the zoom lens in that area. And in that sense, we are, by definition, focusing on a particular area of this big confusion that we call the human mess, the human condition.
Right. And so that's what hypnosis probably does, is that it allows, according to you, allows a person, if he has the ability, to use part of his consciousness that he may not be aware of that he has, to solve different problems for him.
Yes, that's right.
Well, then this brings up another important point about a misconception, about the fact that is hypnosis projected onto the patient? Say if a doctor's going, is it projected onto the patient without the patient's wishes?
See, that's...
That would be very important.
That's right.
You need to be voluntarily involved, and that it can't be foisted or forced on you or done to you from the outside without your knowledge.
Hypnosis is not a projection. It's just simply a way of somebody identifying this capacity in the person who has this capacity, or as Dr. Wayne in Washington calls it, a gift. And to have this gift sometimes can be a real blessing, and it's also a tragedy if you have the gift and you don't know it and you allow it to become a mischievous experience.
So that's a fascinating concept, the gift of being hypnotizable.
That's right.
Yes,
That'll
that's
make a
right.
nice title for one of your books.
Well, that Dr. Harold Wayne down at Walter Reed coined that concept, and it has intrigued me. I think it's a useful way of keeping it in mind.
Herb, in my early years in psychiatry, I was one of those amateur young psychiatric hypnotists. Very rarely we used it with patients, sometimes at parties and so forth. Didn't realize it was a powerful tool, but also began to hear that if one symptom is removed through hypnosis, the patient will, not may, but will only develop another. And for many years, hypnosis went into disrepute because of that concern. And I wonder if you could share.
That's one of the fascinating bits of garbage that has crept into psychiatric thinking. We have yet to find the first case, documented, not just an anecdote, but documented data where hypnosis itself was dangerous, or that a symptom was removed in a non-coercive manner. I'm stressing non-coercion because if you coercively do something, you can create all sorts of things, but there, the pathology there is the coercion, the use of coercion by the therapist. But when a symptom is removed in a non-coercive manner, where the patient is taught and allowed to develop a sense of mastery over it, I have yet to see the evidence of a dangerous new symptom coming about. In fact, what does happen often is we get the ripple effect. The sense of mastery that comes over dealing with that symptom now often extends to solving other symptoms as well.
Hypnosis is controlled imagination. It's just the opposite of sleep. Another way of saying it, it is attentive, receptive concentration with a capacity for dissociation that's reversible. It involves three major components: the ability to dissociate, the ability to get absorbed, and the ability to be suggestible. And varying combinations, these three features are necessary: dissociation, absorption, and suggestibility. The absence of any one of these capacities means no hypnotizability. And in order to identify that, there's a way of testing out what this capacity is. Now, one of the big misconceptions about hypnosis is that it used to be thought that hypnosis was something that's projected onto the subject, and that's totally wrong. There is nothing projected at all. It's a matter of tapping a capacity that the person has. If they have the capacity, no matter what degree, we have something to work with. If they don't have the capacity, there's nothing at all we can do about it. So it just means we have to learn how to test for that capacity, and then on the basis of that, use it in terms of whatever the challenge is in doing therapy. About 1960, I was called by somebody on the staff at Columbia up at Presbyterian Hospital. They had a woman in the hospital who had uncontrollable movements of her legs. And they tried all kinds of medication to get this under control and couldn't do it. And after weeks and weeks of effort there, they thought maybe something could be done with hypnosis. So I was called to intervene. I came up there and discovered that she was very hypnotizable, and in 1 or 2 sessions, I was able to help her control the movements. She was able to walk. And in a few days, she was able to leave the hospital. That so impressed the staff there that they got very interested in the importance of hypnosis in some cases. So then I was asked to do some training in hypnosis, and that led to developing a course. It was 1 week long, a full day, 7 days each semester, and we had students, residents, people came from outside the university to take the course on how to use hypnosis at Columbia. In that sense, I was on the faculty there, and I've been on the faculty ever since. I remember a woman came in. She had been treated for about 4 or 5 different psychiatrists for her seizures that she had, and they couldn't control her seizures with medication. And when I saw her, I discovered that she was very hypnotizable. So in a very short time, I was able to show her how she could control her muscles so she didn't have to have seizures anymore. And then I noticed, with each session we have, I noticed when she would go into trance, she would roll up her eyes. And then at first I thought, well, what's unusual about that? I thought that everybody did that. So then I would systematically observe other patients when they go into trance and notice that everybody didn't have roll their eyes up as she did, and discovered that after dealing with 20, 30, 40 different patients, that there was a variety of movements from when you measure the distance between the lower eyelid and the lower edge of the cornea on a 0 to 4 scale, there would be a variance from a 0 to 4, and some people would go up to 4, which would be the peak movement, and some people would be none, and many people were in between. And then it turned out that as we analyzed the personality styles of these people, that in general, the people who had high eye rolls, so you could see nothing but the whites of their eyes, they tended to be people who were very emotional, they were very suggestible, very hypnotizable, and tend to be somewhat not too well organized. Whereas those people who had only a small movement upward, had a low eye roll, only about on a 1, on a 0 to 4 scale, they were usually people who were very organized, very intellectual, and they put the emphasis on their brain, whereas the people on the high side put the emphasis on their heart. So we had this dichotomy between the brain people on the left, on the low side, heart people on the right side. And then most people were in the 2 to 3 range, were somewhere in between. So this led to a real major change in the way of making diagnosis and making judgments about what would be the appropriate treatment strategy for people with different problems. The recent research in memory recall leads us to this statement. The most reliable statement we can make about memory is that it is not reliable. A famous researcher now, Gerald Edelman, made this point. The memory recall is very much like an iceberg that melts and then refreezes. It's still an iceberg when it refreezes, but the details is quite different. And his point is that memory is not replicative. We don't accurately call, but every time we remember something, we're generating a new combination of events. So although we may recover the gist of something, the details is generated in a different way each time we remember. Now, if that's what happens with memory recall, it raises the question, how valid is it to spend years and years exploring past, to make a change when we know in advance that what we're doing is really generating new fantasies about this and really not getting accurate information. That's a very sobering thought to keep in mind when we spend so much time on trying to remember past, thinking that's necessary to make a change of behavior in today's life experience. This was back in 1959, and she called up and asked me if I could see a patient she had. Said she had a patient she's been treating for several years as a schizophrenic. But as time went on, she had doubts about whether or not she was schizophrenic and wanted to know if I could clarify the diagnosis and whether she was hypnotizable. So after doing a brief history, I immediately discovered that she was a very good hypnotic subject. Well, she was part of that 5% of the hypnotic virtuosos. The question was she schizophrenic? And that was absolutely out of the question. She couldn't possibly be a schizophrenic. For number one, schizophrenics are not hypnotizable. It was clear that the diagnosis was a dissociative disorder. In the old days, we used to call it hysteria. When people who are these hypnotic virtuosos, they are so suggestible, so compliant, so malleable, and so sensitive to cues that if the therapist says, oh, this is just interesting, and now they come up, if the patient comes up with an idea about something, and they say, well, I felt like this then, well, did you feel like you weren't you? Yeah, no, I felt like I was somebody else. That way they're giving them cues to be so they're being taught. And then when the patient says, hey, this is something good, this is, I'm getting more green stamps here, I'm a very good patient here, then it becomes a game. Now that, unfortunately, is what happened. That accounted for the epidemic of multiple personality, when highly hypnotizable people they sensed that the doctor wanted to hear that, and they complied with it. Now, there is such a thing as a multiple personality.